Hi everybody, this is Dr. Soumya again, and I am going to continue to my lecture series on Wilson's disease, and this is the part 2 of my lecture, right? So as a recap of what we have talked about so far, we have seen the metabolism of copper and how copper is utilized in the body, taken up by the liver and absorbed into ceruloplasmin and then released into the tissues. So in continuation with that, what happens in Wilson's disease is that this free copper is highly cytotoxic because it promotes the formation of oxygen radicals, and this leads to hemolytic anemia and chronic active hepatitis, and which can later change to cirrhosis. And sometimes this hepatitis can take a fulminant course, and large amounts of copper are suddenly released from the necrotic liver, and this may also trigger a hemolytic crisis. And we frequently see that Wilson's disease remains undiagnosed sometimes, and it comes to light when we have certain patients who come for other diseases for us, like for example they have an episode of drug induced hepatitis or viral hepatitis, and because there is no resolution of symptoms, we discover that there's a possibility that there is underlying Wilson's disease, right? So I'm going to recount two cases of mine where the diagnosis was pretty straightforward, but this case they came to us pretty late. So the accumulation of copper in CNS can cause neurological, neuromuscular and psychogenic abnormalities, and the deposition in Descemet's membrane can give the KF ring, that is a Kayser-Fleischer ring appearance. This ring usually is visible to naked eye if the neurological manifestations are very advanced, but in early stages is visible with a slit lamp. The kidneys, the skeleton and the heart can also be affected in rare cases or in severe cases, right? So let's move on to the clinical presentation. So the first two words of this slide is what I would like to emphasize, that it is so widely variable. So we have had cases who are asymptomatic, who come with no complaints except failure to thrive or malnutrition or poor appetite, or they come with other underlying clinical disorders like infectious diseases like dengue, which lead on to the discovery of Wilson's disease, and they further on workup we know that it is Wilson's, right? So the manifestations of Wilson's disease are widely variable, but there are four hallmark manifestations, that is the corneal KF ring, liver disease and cirrhosis, neuropsychiatric disturbances, acute episodes of hemolysis. Acute episodes of hemolysis are pretty rare in Wilson's disease, and maybe subacute chronic hemolysis can also occur with these patients, but acute episodes may not be so apparent, right? So the most common of these are the liver disease and neuropsychiatric manifestations, and the symptoms usually arise between the age of 5 and 45 years, although it can present in adults in their 50s. So look at the variation of presentation. It can be anywhere between 5 to 45 years, and in pediatrics there is a dictum that any child presenting with cirrhosis above the age of 5 years is Wilson's disease unless otherwise proved. So this disease can be so common sometimes, but it still remains undiagnosed and the presentation remains highly variable. So let's talk about the KF ring, that is the Kayser-Fleischer ring. It is the clinical hallmark of Wilson's disease, and it is caused by the deposition of copper in Descemet's membrane of the cornea, and it's characterized by the greenish brown color of corneal margin appearing first at the upper periphery. It is usually present in 95% of patients with neurological symptoms and in more than 50% of those without neurological symptoms. So neurological symptoms correlate with the density or the thickness of the KF ring, and it's sometimes visible only by the slit lamp in early stages, and it disappears with treatment. But theory says, or textbooks say, that it may not be entirely specific for WD, that is Wilson's disease, and sometimes in chronic cholestatic diseases like PBC, primary biliary cholangitis, or in children with neonatal cholestasis may also develop Wilson's disease KF ring, but this is highly rare, right? So liver disease, the manifestations of liver disease is of any variety, and it can be severe, any severity. So the presentation can include an asymptomatic hepatomegaly, or somebody presents with just abnormal LFTs even as early as the first year of life, and sometimes just a fatty liver which is discovered on the ultrasound, or it can be an acute hepatitis which resembles autoimmune hepatitis and can come with a sudden onset of liver failure or chronic cirrhosis, which can be compensated or decompensated. So I would like to recount one case of ours which we at Manipal treated, where there was this girl. She was 16 years old and she was admitted for dengue, and she had persistent thrombocytopenia, and beyond 10 days, 12, 15 days, the thrombocytopenia didn't improve and she had a splenomegaly too. So to work her up further for her thrombocytopenia and splenomegaly, we suspected that she might have hypersplenism, and we got a portal vein Doppler done as well as ophthalmic examination done, and both were positive for KF ring as well as portal hypertension, and that's when we did the first further testing, and she was positive for the ATP7B gene. So she was a 16-year-old girl. She was pretty asymptomatic, but she still had all the signs, right? And we had one more boy who is about 12 to 13 years old, and he came with behavioral manifestations as complained by his parents, which said that he had emotional lability, he used to laugh inappropriately, and there was a regression in school performance, academic performance. So he had classical manifestations of Parkinsonism like the rigidity, and he also had a KF ring, and he also tested positive for ATP7B gene. So there can be very wide variation of manifestations, but it depends on us to pick it up and treat them early. So the important practical message here therefore is that suspect Wilson's disease in any child with undiagnosed liver disease, especially above the age of 5 years. So the clinical manifestations in the hemolytic system is that it can cause a Coombs negative hemolytic anemia, and it can be the only initial symptom sometimes. Chronic low-grade hemolysis, like I already mentioned, can be associated with Wilson's disease even when the liver disease is not clinically evident. So clinically, these patients may have an overlap where there is equal elevation of both direct bilirubin as well as indirect bilirubin. So working up for hemolytic anemia may also be necessary. So marked hemolysis is commonly associated with severe liver disease because of the release of copper, like I said, and the decay of liver cells may result in a release of large amounts of stored copper, which further aggravates hemolysis. So coming to neurological disease, it can have a wide variety of manifestations, and they are very interesting. So they can present with movement disorders like a tremor or voluntary movements, drooling and dysarthria. They can have rigid dystonia, a pseudobulbar palsy, dysautonomia, migraine headaches, or insomnia and seizures. So they can also have a lot of psychological changes, and this can be the first clinical manifestation appearing simultaneously with hepatic signs or years later, and they can be extremely subtle and can be intermingled for many years. We may not be able to know, and they may also develop very rapidly, leading to complete disability, right? And psychiatric disease, so up to 30% of patients with Wilson's disease initially present with psychiatric abnormalities, and it is very unfortunate that parents sometimes don't pick it up that their child has a psychiatric disease which may be curable or treatable, right? So in the patient which I described, the parents thought that the child was having functional issues, that the child didn't want to go to school, and the child also didn't want to complete homework, and because of the behavioral changes they thought that it is not really a huge problem. It is only when the grades started falling that the parents became concerned. So the presentation can include depression, neurotic behaviors, personality changes, and psychosis. So there is a rule of thumb in the outpatient or in the floor, pediatrics floor, that any child with a declining school performance must always be evaluated for secondary causes like Wilson's disease. So, in children with declining school performance, personality changes, impulsiveness, labile mood, and inappropriate behavior are frequently observed, and these are frequently misdiagnosed as behavioral problems associated with puberty. So, it is very important for somebody to have a high index of suspicion, and it is essential for us to pick it up and treat this, because this is a treatable cause and it's possible that the changes can improve, right? So this is the second part of my lecture, and I am going to continue this series on Wilson's disease with the diagnosis and management in the next few slides. So please feel free to leave comments or any queries that you have, and I would be happy to answer them. So this is Dr. Soumya signing off for today with today's lecture. Thank you everyone.